Good morning, everyone. It's a great pleasure for me to welcome you all today to this symposium. Both those of you who are present in the room and those of you who are listening to this live stream broadcast. Thanks very much for joining us. And I know many of my colleagues in low and middle income countries are probably it's either nighttime or evening or early morning like us. So welcome wherever you are. First, housekeeping announcement. One of our opening speakers is on the way, Dr. Hennis, who is Director of Non-Communicable Diseases at the Pan American Health Organization. So he should be with us. So there's been a slight change in schedule. I flipped my talk with him, and hopefully his presentation will follow after mine. So first of all, I'll do a proper welcome. What I'd like to do today is also introduce to many of you who may not be familiar with the work of a specialized unit here at Johns Hopkins called the International Injury Research Unit. Then talk to you a little bit about the program thanks to which we are gathered here today, the Bloomberg Philanthropies Global Road Safety Partnership, and update you on the 4.5 years of work we've done on monitoring and evaluation with many colleagues who are present both on the internet as well as in the room. I'll mention a couple of things about some of the additional work beyond monitoring and evaluation that we've been involved in, particularly road trauma care and training, and also mention a few of our project achievements, as we'd like to call. There's lots of space up front. For those of you who are entering, feel free. Don't be shy. The tables are empty right here, and bags are available on each seat. So first of all, on behalf of not only myself, but also the International Injury Research Unit, let me welcome you to Baltimore for those of you who are flying in from other countries, but also to Johns Hopkins University and the Bloomberg School of Public Health. I'm very glad that our dean was able to spare a few minutes. He's actually in another meeting, but we dragged him away to welcome all of you, and it was a pleasure to have him. I also want to thank many of you for your collaboration and partnership. Many of you, both online as well as in the room, have been working with us not only in this project, but in other projects as well. And so thank you for your friendship and for the warm collaborations we've had with you. Our unit is very excited to host this seminar and symposium. We are also very excited to be able to share all of this material that not only us, but many of our partners have collected. And throughout the sequence of today, I hope you will get an opportunity to hear about risk factor information, about trauma care, as well as about monitoring and evaluation. So let me begin by first taking just a few minutes, especially to those of you who are not familiar with our research center, to talk to you a little bit about the Johns Hopkins International Injury Research Unit. We are actually quite a young research unit. We were established in 2008. The Johns Hopkins University has 10 schools. One of them is the Bloomberg School of Public Health, in which you are currently, for those of you in-house. And we have 10 departments in the school. We are located in the Department of International Health, which happens to be the largest department of the school as well, with nearly 175 full-time faculty members. We are very pleased that we have hosted ourselves within a global health department so that injury prevention becomes a critical conversation in global public health. And that has been the main mission of our unit. We are also very pleased that as of 2010, we are one of the 3 WHO collaborating centers, the World Health Organization collaborating centers in the US. And I'm very pleased that we have representations from the Centers for Disease Control here, who are also a collaborating center. We work very closely with the Pan American Health Organization. PAHO is also a regional partner, and we are delighted that we have collaboration with PAHO present. Now, the International Injury Research Unit has 3 main strategies. We do research, we collaborate, and we train. And I think many of those are similar to, I'm sure, things that you're doing. It is through these 3 research strategies that we hope to identify effective solutions to the problem of injury prevention around the world, and not only just to identify solutions, but also facilitate and encourage their implementation and adoption in real-world settings. And I hope that many of you will keep an eye to that policy and practice as we talk about our work through the rest of today. We believe that injury prevention and control is a complex issue. It's not for one actor or one organization to confront. It is a multidisciplinary, multi-sectoral issue. And we hope that our 3 strategies, as we implement them, are able to confront this complexity over time. We are also very pleased that in these 3 strategies, unfortunately, I'm not going to spend time discussing what we do in each one of these 3 elements, but we do research on intervention studies, we do economic analyses, we do surveillance. You'll hear some of this. We love to collaborate with NGOs, with governments and private sector. And of course, we are a university-based research unit, so we train and we teach and we engage in academic and scholarly work, as I'm sure many of you also in your respective units. We've had the pleasure over the past 6 to 8 years of working in many, many different countries of the world. Many of you are present. We have over a dozen countries already represented here physically and many more on live online. It's a great pleasure to have friends as we travel around the world. Since the symposium today is focused on road traffic injuries, I'm actually just want to emphasize that the Johns Hopkins International Injury Research Unit certainly works in the area of road safety, but that's not all we do. We actually work in the area of drowning prevention, for example. We have a very large project going on in Bangladesh. For those of you who are interested, we can talk about these issues in coffee breaks and during lunchtime. We work on child injury prevention. We have projects in Pakistan, in Malaysia, in Uganda. We work in the area of poisoning prevention, very exciting new work starting in Sri Lanka. We work on migration and injuries in occupational fields. We are exploring work in the Middle East as well as in South Asia related to these populations. And indeed, we are not only interested in the incidence and the acute management of injury, but also in the long-term outcomes. And we have a multi-country study which has just started, which covers Asia and Africa, in which we are trying to estimate the long-term social, health, and economic impact of injuries. So all in all, the spectrum of prevention, secondary, primary, tertiary is available, and we hope that many of you will engage with us. Because one of the things we love to do is to collaborate. We have collaborated with non-governmental organizations around the world, and we're very proud of our collaborations with them. We collaborate with governments and the public sector. In fact, through the auspices of the project that I'm going to talk about, we've had a great opportunity to talk to them. And in many countries, we have friends and ministries of health and transport and safety. We also collaborate very closely with the United Nations, and I'm delighted to have senior leadership from the Pan American Health Organization in the room, and with the other elements of UNICEF and UNDP and so on. We've had lovely relationships with them. So I hope that in a few minutes gives you a little bit of the spectrum. You have some materials in the bags which are available on every seat. If you would like more information on any of our projects, please contact any one of our staff and, of course, visit our website. What I'd like to do now, with that brief introduction, is really get into the meat of the conversation. One of the reasons we are able to hold this symposium is because of the Bloomberg Philanthropies Global Road Safety Program. I think to this audience, it is moot for me to remind you of the burden of road traffic injury prevention. Over about 1.2 million people die every year, and millions more get injured and disabled. Many of you, of course, are epidemiologists and biostatisticians, and you may have your own ideas about whether it's 1.21 or 1.23 or 1.31. That conversation we can have later. The question is, it's a big number, and we are all worried about it. It's unfortunate that we are the top, road traffic injury is one of the top 10 leading causes of death. We don't like that. We don't want it to be a leading cause of death. And I think in this room and online, we have many, many colleagues who want to change that. We want it to be the 50th or the 60th leading cause of death, because that will be our success. It is in view of this that for the first time, about 5 years ago, a private philanthropy headed by Mike Bloomberg, former mayor of New York City, decided to invest in the area of road safety. The aim of that investment was really to reduce both non-fatal and fatal road traffic injuries in 10 low and middle income countries. And they invited partners to join that effort: the World Health Organization, the Global Road Safety Partnership, the Association for Safe International Road Travel, or ASSERT, EMBARK, the World Resources Institute, and the Global Road Safety Facility of the World Bank. And I'm very happy to see representation from the bank present here today as well. All of us, and in addition to our School of Public Health, representing by our unit, were delighted to work together to begin this process in early 2010. And it's unbelievable that we've already reached the end of, nearly the end of our 5-year process. Just a word to recognize our other partners. The World Health Organization has been critical in helping ministries implement strategies for road safety and looking at things like social marketing. Our role has been largely focused on monitoring and evaluation, with a very important role on training and capacity development as well. Our colleagues at GRSP have been working hard with respect to enforcement and police training. Our colleagues in the Association for Safe International Road Travel have been working with the civil society and non-governmental organizations. Embark has been looking at infrastructure and looking at issues of urban development and safety. And our colleagues at the World Bank have been working very hard to look at infrastructure assessments, working with governments in promoting road safety. So when I talk about the project, I want to be very clear that we are a consortium and we work together incredibly well. Today, however, I'm not here to talk about the work of other consortium partners because they are best able to do that. I really want to focus in on the work that we have done between ourselves. So let me share with you an update on the monitoring and evaluation that our unit has been leading with many collaborators and partners around the world. And again, as I mentioned, many of you are present in the room and online, and my deep gratitude to all of you. Let me first say that collecting data over 10 countries with multiple sites, so we have nearly 30 sites around these 10 countries, is an incredible exercise and was extremely rewarding. And again, could not be possible without hundreds and hundreds of data collectors and data managers and project coordinators who are not going to be named today, but I hope that they understand their contributions are critical. Our approach to this project was to look at both secondary and primary data. We recognize that governments and other agencies collect information, health sector, transport sector, road transport, etc. And we want to acknowledge that, and we have attempted our level best to collect that secondary data and use it as part of our monitoring and evaluation efforts. But we also recognize that the secondary data available was actually quite disparate, sometimes not available for some years, sometimes inaccessible, sometimes using different definitions, and so was not entirely comparable. And therefore, we've made a huge investment in collecting primary data as well. And obviously, when you do primary data collection, you are better able to control definitions and processes and methodologies, a lot of which you will hear during the course of this symposium. Now, we used multiple methods. Today, you will hear about some of them in detail. I'm not going to spend enormous amounts of time on that, but simply to say that we used observational studies where our colleagues stood on the roads and observed people wearing helmets and seatbelts. We used roadside interviews where we stopped drivers and talked to them on the roadside. We also used qualitative, in-depth interviews and focus group discussions to talk to people about their knowledge and attitudes and practices. We've established injury surveillance systems and trauma registries in countries. And we also had the opportunity to do a few selected small household surveys, going house to house and asking people about their experiences with road safety. So we've used a plethora of methodologies in order to understand better using primary data collection strategies. We are working in 10 countries: Brazil, Cambodia, China, Egypt, India, Kenya, Mexico, Russia, Turkey, and Vietnam. As of January 2010, all of these 10 countries were low and middle income countries. That may have changed this year for some of them, but at the start of the project, they were all LMICs, and you can see that generally speaking, we had at least 2 sites in every country. At the beginning of the project, extensive stakeholder engagement was done with national governments, and they were asked to select to work on 1 or 2 from 4 risk factors, either helmets, seatbelts or child restraints, speeding, and alcohol. So each country decided to work on 2 risk factors at least. In some cases, you will see that countries decided to work on 3 risk factors as well. But generally speaking, that was the approach. And the idea was that we have evidence-based interventions against these risk factors. So the challenge for monitoring and evaluation was not only are we dealing with 10 countries and 30 sites, but now we are dealing with 4 different risk factors. And how do you develop methodologies to put that? And you can see that we've taken our 5 approaches, and in generally speaking, we've done observational studies in all countries and roadside surveys as well. We used selectively our other 3 strategies of surveillance, qualitative interviews, as well as household surveys. So the crux of our evaluation was really dependent on live, real-time observations and roadside interviews. Now, the critical thing for us was recognizing that in observational studies, 1 observation or 2 observation is not enough. So over a spectrum of nearly 3.5 years, we've done multiple rounds, and as this complex slide demonstrates to you, we have situations, and for example, in Cambodia, where we already have 21 rounds of observational studies done across this time period. In most countries, we have 5 or 7 rounds or more. For those of you who are more statistically minded, you will understand that the larger the number of rounds, the greater the rigor in our analysis later on. For roadside interviews as well, although that involves stopping people and interviewing them and spending time, we actually have more than 7 to 8 rounds in most countries of these roadside interviews. For those of you familiar with the injury literature, you will know that in many cases, in fact, we see publications with 1 round and 2 rounds. So we wanted to really go and extend that approach. We've also done surveillance, as I mentioned, and setting up surveillance systems and trauma registries. In terms of sample sizes, again, for those of you with interest, I just want to identify that I think we have collected some of the largest sample sizes that have ever been reported in the field. So for example, we already have nearly 1.6 million observations done in India. We have another 1.57 million observations done in Russia. In Turkey, we have over 1.2 million observations. In fact, even in roadside interviews, when we are stopping people and interviewing them, we have thousands of people. We've done over 15,000 in India already. Incredibly large sample sizes. Overall, we are very proud that as a consortium, we have now collected over 6 million observations across these sites. We think that that gives us the strength to talk about some of this, and we believe that it is absolutely vital to share this information across the world for road safety. I cannot give you results across the 6 million observations for 2 reasons. One, it's pretty impossible to do that in 5 minutes. And secondly, a lot of my colleagues and partners today that you will hear from many different countries are actually going to share their results with you. So I'm not going to take away from their presentations. But I will give you 2 examples. Here's an example from our seatbelt or child restraint observations. In the seatbelt column, you will see the first column says the first observation. The first observation occurred either in 2010 or in 2011. And then the next column says the last observation, which happened sometime in 2014. And you can look at the difference. My colleagues later today will show you time trends and other interesting graphs. An example, of course, comes from the site of Ivanovo Oblast in Russia, where when we started, seatbelt wearing rates were around 45, 43, 48%. This year, they're up at about 92%. We see this change. I've highlighted a positive change, but you can also see there are other places where things have not changed positively. And that doesn't mean failure. What it means is we need to understand why this is so. Why did it happen? Was it lack of intervention? Were there other things happening? Another example I wanted to show you is with motorcycle helmet. Particularly in parts of Asia, this is the most common vehicle of transport. And helmet wearing is critical and a key evidence-based intervention for traumatic brain injury, for example. An example comes from Vietnam, where when we started the project, helmet wearing rate for drivers was about 30%. Now it's above 80% already. And so these successes demonstrate how if you have the right type of data, those who are implementing these interventions will have the opportunity to be informed and can then manage their interventions and their implementation. As I've said, I'm not going to spend time discussing the details of this. I wanted to share these with you simply because I wanted you to get a framework of the approach and the methodology that we have used. And I hope that during the course of today, you will hear a lot more about this. Our responsibility was not just focused on monitoring and evaluation. We've also done 2 other things. We worked a little bit on trauma care. And after lunch today, you will have a whole session on that. But simply to remind everyone that we've done a 4-year effort, particularly focused in Kenya on trauma care. This began with a new approach that we developed called the Trauma System Profile that we implemented in Kenya to evaluate the system. And then our program of intervention, which we call the 9-point plan. Dr. Ken Stevens, who's been managing this work for us, will talk about that considerably after lunch. But here's a snapshot just in terms of our training in trauma care. We've already trained over 500 individuals in Kenya on clinical skills, nearly 200 pre-hospital care providers, a critical component. We actually have colleagues from Kenya in the room. We've trained over 100 people in hospital management, and we've done a number of seminars and workshops and so on. And if you're particularly interested, I urge you to contact our trauma care team and converse with them. I've mentioned that as an academic center, we, like many of you, are involved in training and capacity development. So I'll give you a quick snapshot also of the training that we've done. Our strategy for training and capacity development was three-pronged. We believe in training by doing. So as we engage with our partners and our colleagues, we have active engagement, we do learning processes, we engage with each other, and there's a learning process that ensues. But we also do workshops. We've already done nearly 60 workshops in these 10 countries, and we've trained hundreds of people through those workshops, ranging from injury prevention to trauma care. And we've developed courses, both online courses and in-person courses, and those of you who are leading centers and institutions, you're welcome to engage with us in this. And all 10 countries were the recipients of this capacity development program. Let me mention one specific example. Thanks to the support of Bloomberg Philanthropies, we have now developed a free online training program for road traffic injury prevention and control. It's a 6-module program. It's entirely free, but it does require the candidate to self-learn, to pass each module, and at the end of the 6th module, they will receive a certificate. So from Johns Hopkins, Bloomberg School of Public Health, and our unit, that they have passed this training program. I welcome your interest in that, particularly those of you who are listening online. If you want to go to our website and look at that, you're most welcome. So let me now bring this conversation to a close by talking about some of our project achievements. And I say this with great humility as well, because I think hundreds of people have been involved, and I'm really summarizing some of these important achievements. First, let me begin by saying that the establishment of a well-coordinated system to collect data across 10 countries and 26 sites has been incredibly powerful, both for me as leading the project from here, but also for many of my colleagues from these 10 countries. It's an incredible system. We had our challenges, but we surmounted them, and you can imagine these millions of observations being collected and sent to a central storage system, and we are really, really happy at the working of our consortium. Second, I really think, and particularly for those of you who've been following the field, that we've actually new information for the field of road safety. Some of this data on seatbelt wearing or speeding was not known. We didn't know how many people wear seatbelts in Turkey before this project. Now we do. We actually didn't know what the speeding rate was in parts of Russia. Now we do. And so this is incredibly new information, and the World Health Organization has been using this information already for their purposes. And as we are saying that we are now collecting the information and even attempting over the next year, look out for the information to come out in public access. We really want all of you and many of our colleagues around the world to use this information. Thirdly, we are very proud of our training and capacity development efforts. Nearly 4,500 individuals have been trained by us over these 4.5 years, and it's been incredible, both in person and online. And many of our trainees, we actually meet in the field. People come up to us and say, we took your course. And by the way, we welcome feedback. And we have changed. We have changed our strategies. The feedback has been incredible. It helps us improve our training and delivery methodologies. I also want to make a special mention of our scientific publications. Although our project is not over, I mentioned to you that we are ending the project in December, we already have 50 scientific publications already online for all of you to read. Actually, on each table, we have copies of 2 special issues, one that we did in 2012 in traffic injury prevention, and one that we did last year in the journal Injury. More than 50 authors from around the world have collaborated to publish those, and many more articles will be appearing over the next year. We are indeed very proud of that and hope that many of you will read those papers. And again, we welcome feedback on our information. And then most importantly, of course, as Dr. Bishai mentioned at the start of this symposium, that we are truly interested in raising the global profile of road traffic injury prevention, not only in terms of the burden, but very importantly, in terms of what can we do about it. How can we actually reduce this burden? What are the strategies? And we hope to network and engage with many more colleagues in health, in transport, in safety, in environment, in sustainable development, in urban health, etc., etc. This is a field where everyone has an opportunity to contribute and indeed play their role. So I hope that this provides a summary of some of our approaches, particularly in this project. I hope that you will take the opportunity to read a lot more, both in terms of our academic papers as well as our other publications. And all of us here, at least at the International Injury Research Unit, are looking forward to engaging with all of you. Thank you very much.